Our next subject is one that we often get asked about a lot because we spend a lot of time on clear cell carcinoma, but not a lot of time on emerging treatments for non-clear cell carcinoma. So I am really happy to announce that today we have Dr. Prithvi Murthy, MD. He is a fellowship-trained urologist with expertise in the management of urologic cancers such as prostate, bladder, and kidney cancer. First and foremost, he believes in thoroughly educating his patients regarding their urologic conditions and treatment options so that they feel empowered to help create a plan of care. And by the way, I think that's a really key point. I think doctors that talk about empowering the patients are doctors that I like to spend time with because I think they place a significant role on all of us to play a huge role in the treatment of our renal cell carcinoma. He is particularly adept at utilizing robotic and other minimally invasive surgical modalities. I love the robot. The Da Vinci robot did my prostate many years ago. He is a native of southeastern Michigan. Dr. Murthy obtained his undergraduate degree in biomedical engineering from the University of Michigan in Ann Arbor. Go Blue, I have to say, sorry. He went on to earn his medical degree at the University of Chicago, Pritzker School of Medicine. I don't know what their football team is, so we'll just say Go Good Medical School, where he's awarded the Dean's Scholarship for Outstanding Promise in Medicine. He then completed, this is interesting, urologic surgery residency at the Cleveland Clinic, Glickman Urological and Kidney Institute. And being a Clevelander, Cleveland Clinic's a great hospital, which is consistently ranked as the #1 urology residency training program in the country. From there, he obtained further subspecialty education in genitourinary malignancies at the Moffitt Cancer Center in Tampa, where he completed a research and clinical fellowship accredited by the Society of Urologic Oncology. Dr. Murthy endeavors to use his academic background to bring cutting-edge treatments to his patients at convenient locations close to their homes. And that's another big issue for all of us. We don't have to go across the country to find great doctors, and that's a point we've been emphasizing lately in several different communities. Outside of his clinical practice, Dr. Murthy enjoys trying new restaurants, I do too, racket sports, I used to, and traveling with his wife and 2 daughters. I do with my 3 daughters. So with that, I'm going to turn it over to Dr. Murthy.
Thanks. I didn't realize how long that biography was until Joel read it. I'm sorry. I'll cut it out for the next time. Just a little bit about myself. I grew up in Michigan. My wife is from the western suburbs here in Barrington. So when we finished our training, we decided to come back. I live in LaGrange, but my practice is predominantly in Orland Park, going as far west as Joliet. So for those of you that are from the area, I'm mostly at Silver Cross Hospital, South Suburban Hospital, and St. Joe's Hospital in Joliet. Another very fun thing, Joel talked about community in this network of kidney cancer, patients with kidney cancer. Dr. Tallman and I went to medical school. Is Dr. Alam here? Dr. Alam and I grew up a town away from each other in Michigan, and Dr. Stadler probably doesn't remember this, but he was a consultant for my dad's metastatic prostate cancer case when I was a 4th-year medical student at University of Chicago. So it's a close network for the patients, it's a close network for the doctors as well. So thank you for allowing me to be here today, and thank you for spending your Saturday with us. Everybody probably has a sugar hangover from Halloween, but we'll try to do this. So my talk is mostly going to be on the surgical management of non-clear cell renal cell carcinoma. I spoke with several patients here today that have non-clear cell subtypes, and I just think by the fact that this is a Kidney Cancer Foundation meeting, you're going to find patients that have non-clear cell subtypes and also the more advanced forms of disease states. My talk will be predominantly based on localized non-clear cell and kind of going through the lens of what a surgeon sees when we see a new patient in the office for evaluation and how that translates into forming a plan of care. If questions come up throughout the talk, interrupt, or we have time at the end of the chat as well. So Dr. Tallman went into what is a clear cell. This is probably the most famous pathology picture in kidney cancer. It basically means the lipid and the glycogen in the cell were washed out when they did the staining. It looks clear. We're simpletons, as he mentioned, so we call it a clear cell. Clear cell is by far and away the most predominant subtype of renal cell carcinoma, representing about 75 to 80% of cases. Papillary, collecting duct, sarcomatoid, chromophobe really represent the minority of cases. Papillary about 15%, chromophobe about 5%, and all other subtypes representing about the remaining 5%. Here on the right side, you can see some of the clinical associations with these various subtypes, but we are going to really focus on the 25% that is non-clear cell today. How detailed can we get? Dr. Tallman also went over this slide. Basically, 95% of kidney cancers are, represented by either clear cell renal cell carcinoma, papillary renal cell carcinoma, or chromophobe RCC. The remaining 5% are the ones that only came out in 2022, where the World Health Organization classified an entire spectrum of molecularly defined renal cell carcinomas, and that's where we're getting all these details. And why there may not be an initially clinically translatable approach to defining these, the more we figure out about how they, the pathogenesis, how they're created, which was one of the questions asked by the audience, the more we're going to figure out what therapies work and what don't work. So it is important to invest our time and efforts even into discovering this 5%, even though it does not represent the majority of cases, because that's how we're going to get 100% of patients better. So prognosis and non-clear cell. Generally, the non-clear cell subtypes are as favorable, if not slightly more favorable, than clear cell renal cell carcinoma. We know that there's bad actors of any subtype, but in general, chromophobe tends to do better. Papillary does the same, if not as well as clear cell, and collecting duct, sarcomatoid, rhabdoid, medullary renal cell carcinoma tend to do worse. Dr. Tallman briefly mentioned this. So when I started my training, pretty much everybody went to the operating room without a biopsy. I was at a conference last week listening to Dr. Robert Uzo from Fox Chase Cancer Center give a lecture. He's probably one of the world's foremost experts on management of surgical kidney cancer, and he said in his clinic almost every single patient gets a biopsy. So that is a major shift from what we were doing 10 to 15 years ago. What has changed this kind of paradigm shift? Number one, there's a huge concern about tumor seeding in the initial biopsy series. Patients still ask me, hey, if you stick a needle in my cancer, are you going to spread it around my body? The answer is no. We no longer do that because we have a coaxial technique, and the contemporary literature suggests a less than 0.2% seeding risk. I think it's probably even smaller than that, and those are just other cases that were detected. There's also concern that this is non-diagnostic. This is no longer the case because instead of fine needle aspirates, which are very thin samples, we're doing more core biopsy techniques. We're getting larger pieces of tissue for histologic sampling, and now we have dedicated genitourinary pathologists that really are experts in looking at those cancer cells underneath the microscope and give us more stratification regarding what that cell is or is not. Surgery used to be the default. It was kind of like a one-size-fits-all approach. You're getting a radical nephrectomy or you're getting a partial nephrectomy, and that is not the case anymore. So having that histologic data and knowing what subtype of renal cell carcinoma that is, even if it's a clear cell, we can go by grade. It really does change the management plan. So I'm going to talk a little bit about that. So biopsy is a useful companion. This is just a little schematic of what it means to do a coaxial technique. So basically you have an outer sheath that goes right to the edge of the tumor, and then you have an inner needle that goes in, samples the tissue, and then brings it back into that outer sheath, so that actual core of tissue is not touching anything else in the body besides the inner stylet. So it's almost poking, it's like a hole in a hole. So I want to go through some cases. These are my own patient cases. These are all from the last year, so these are all pretty contemporary. So I want you to focus on this region right here, okay? So this is a healthy 49-year-old female, and she presented with a loss of appetite, okay? And you can see this tumor right here. She has a cyst in her other kidney. This is a simple benign cyst. We see that all the time, but this is what I want to focus on. And when a patient gets a report for a CT scan like this, it's going to read something like heterogeneous, lobulated, exophytic with endophytic components encroaching on the renal sinus and the hilum complex, and they're going to give some score, 8 out of 10, 9 out of 10. So if you read that and you're a patient, you're like, oh my God, your life flashes in front of your eyes. But like Joel said, this is not the case. And this is why it is important to have get second opinions, get third opinions. Don't ever feel like you're offending your doctor if you ask to see somebody else. You have to be your own best advocate. And you need someone that does a lot of kidney cancer surgery to look at that CT scan and actually say, hey, this really isn't that aggressive. So this patient came to me. She thought she needed to have her entire kidney out. I looked at it and said, this is probably a less aggressive form of kidney cancer. If I had to bet, it would probably be a papillary. And sometimes you're right, sometimes you're wrong. Sometimes it's a indolent clear cell, sometimes it's a chromophobe. But this patient ended up having a robotic partial nephrectomy. She ended up having a T2 papillary renal cell carcinoma. It's T2 just because of the size. It was greater than 7 centimeters. And followed her up with surveillance scanning. She was no evidence of disease. So this is a patient where I did not feel the need to biopsy her because I looked at it and I kind of thought this was a papillary. Sorry. This is a second patient. So this is not, he's not as healthy. He's a 60-year-old guy. He's like a Chicago medium is what I call him. So he's like tailgating on Sundays, eating brats. You know, he wears like an extra large, but it's a Chicago medium. He has a history of leukemia. He's status post-chemotherapy. Why is that important? Because generally patients that have undergone recent chemotherapy have lower blood counts, lower white blood cell counts, lower red blood cell counts, may not be as capable of fighting infection in the postoperative setting. He has atrial fibrillation, so he's on a blood thinner. And then, you know, surgically relevant, he has 3 renal arteries, and he has a lot of fat around his kidneys. And, you know, we kind of call this toxic fat in the community. You generally see it in older gentlemen, but it just makes getting the fat off the kidney a real expletive when you're in the operating room. And his BMI is about 40, okay? So here I want you to focus in this part of the seat. Can you see my mouse up there? Yeah, okay, so focus up here. So there's the mass right there. And again, it's encroaching close to kind of the renal sinus. And when I looked at this mass on the CT scan, you kind of notice that little hypodensity or that kind of soft spot in the center of that scan. In rare cases of chromophobe, you'll see something that's called a central scar. And we all learn about it when we're going through our surgical training. And they make it seem like, yeah, that's a dead giveaway. It's really not. It happens extremely rarely. But sometimes if you pick that up, you can kind of modify your thinking. So for this patient, I did a renal mass biopsy on him. And this is kind of the worst thing that pathologists can tell you because it says oncocytic neoplasm. It's not really helpful. You don't know if it's a chromophobe renal cell carcinoma or if you don't know if it's a renal oncocytoma, which is a benign lesion that you don't need to really do anything about. So this was called as an oncocytoma versus a chromophobe renal cell. And they also called it a potentially grade 1 clear cell. So I really was like, all right. All I really knew from looking at that biopsy result was that this is not a super aggressive thing. So I talked to the patient about surgery versus observation, and these are kind of the patient factors that Dr. Tallman was mentioning in his previous talk, and this is how I counseled the patient. He has a potential for his leukemia and lymphoma for coming back. He may need chemotherapy down the road. He may be less healthy or able to tolerate surgery in 5 years than he is right now. His EGFR was 63. So down the road, his kidney function may worsen, and if we did have to do a total nephrectomy for some reason, he may not be able to have as robust of a reserve down the road. He also has 3 arteries and this toxic fat that I mentioned, and his tumor location, left-sided upper pole, is generally one of the harder places to do a robotic surgery just because of reach of the robot. So I actually signed him up for an open flank partial nephrectomy. Unpopular in some communities to do open surgery. I think that there's definitely still a major role for it. Patient preference, surgeon preference, and just making sure that you can get a patient a good operation and off the table quickly. So he ended up having a 6-centimeter mixed oncocytoma and chromophobe renal cell carcinoma. And this is generally, it's a overall benign lesion with chromophobe renal cell carcinoma within it. And he's doing well. This is my 3rd patient. I saw this patient not last Friday, but 2 Fridays ago. So she's a healthy 72-year-old female. And you can see she has a lot of metal in her body. She probably lights up the scanner at TSA when she goes through. She's had a 10-level spinal fusion, and she's had extensive abdominal surgery. She told me that she had her entire colon removed for a reason that she cannot remember, and she has high-volume diarrhea. And when I examined her belly, she, kind of zipped up from the top to the bottom. So what am I thinking about this patient when I'm thinking about a surgical candidate? I'm thinking, can I position her on an operating room table without causing serious back issues? If I do get into her abdomen, is there going to be significant scar tissue, and will I actually harm her by doing surgery as opposed to just watching her? She has excellent kidney function as is, so it's not like she would significantly compromise her renal function by having a surgery. So just a couple of other things that I want to show you from a surgeon standpoint. This is like one of the largest livers I've ever seen. So if you see this bottom aspect of this liver, it's basically going to where my hip bone is here. So most people's livers end right around where their bones are over here. Her liver ends below the level of her hip bone, which again, it's not a huge deal, but it's something they have to think about because it makes surgical access sometimes challenging. And then when you look at her mass over here, this is her mass, you can see that it's not very bright, I guess. It's well circumscribed, and it's exophytic, meaning it's in a peripheral location of the kidney, away from the major blood vessels, away from that ureter that Dr. Tallman showed us earlier. So what do we do for this patient? We could do surgery, we could do ablation, or we could do surveillance. And there's patient factors, her anatomy, her mobility, and her ability to have a good surgical recovery. There's tumor factors. Where is it located? Is it an easy place to do a surgery or an ablation, or is it a hard place? Does it look very aggressive? I don't think so. So what did I actually recommend for this patient? I recommended a biopsy with cryoablation. This is just some data on cryoablation, which is basically where you stick a needle into the mass and you turn into a giant ice ball 2 times, and it causes tumor killing that way. There's no difference in cancer-specific survival at 5 years, so it's equivalent to surgery for renal masses that are under 4 centimeters, and the local control rates are greater than 90% at 5 years. If you have a local failure, you freeze it again, and that control rate is equivalent to that of surgery. So this is a really, really good option for patients that have small renal masses. And my practice predominantly, if somebody has a small renal mass like this, I tend to not do surgery for them. I tend to actually recommend them for some form of ablation because there's less risk involved with an ablation than a major abdominal surgery for kidney cancer. That's the reality of it. So the practice has now evolved to doing surgery for patients with larger, more complex tumors where there isn't a less morbid alternative. Another treatment option that I spoke with her about is something known as active surveillance. Active surveillance is not the same thing as watchful waiting. I think that's a very important thing to understand. It's not a set it and forget it where you just say, hey, you're good, we never have to monitor those again. It's a series of iterative CT scans with physical examinations and following up with the urologist where we review the imaging and look for tumor growth rate, we look for changes in its aggressive features, and we ask the patient how they're doing and how their life has changed since we initially made their diagnosis. The risk of metastasis at less than 2 years, at 5 years is less than 2%, and the cancer-specific survival in a population that is observed is greater than 99%. And Dr. Alam actually was one of the co-authors, I think, on this very important paper. It was published in the Journal of Urology this year, which is our major journal for urologists. And you know, this is a 12-year experience following thousands of patients across 3 major academic institutions with renal masses. Okay. So what's down the pipeline? This is really cool. There's actually novel imaging. So there is a basically chemical called girentuximab. And what girentuximab is it's an antibody to a chemical on the surface of clear cell renal cells that is called carbonic anhydrase 9. And more than 95% of clear cell renal cell carcinomas have this enzyme, and this antibody can target this enzyme, which makes it very specific for detecting clear cell renal cell carcinoma, which is really, really cool when you think about it. Because it's not only telling you whether it's a cancer or not, it's telling you specifically the subtype of a cancer without having to remove the tumor, without having to do a biopsy of the tumor, without having to have a pathologist look at it under the microscope. And basically, it can rule out cancers 86% of the time and rule in cancers 87% of the time. So it's a highly accurate test. And I don't know how well the images are showing up here, but that little red dot there, that's around a 1.5 centimeter tumor that it was able to say, hey, this is a clear cell renal cell. So it's size agnostic. Okay, and here you have a larger tumor that didn't light up on the scan. And you know, that says that, hey, this could be a chromophobe, this could be a papillary, this could even be a benign lesion, right? So not something that we have to hurry and go to the operating room for. So there's a lot to take away. The main thing is non-clear cell still only represents about 25% of all renal cell carcinomas, but it's a very important subset of patients that we need to be taking care of. The majority tend to be less aggressive than conventional renal cell, but we obviously know that there's bad actors in all situations. I think as patients, it is important, if you feel like it's appropriate, ask for a biopsy. See if you can de-escalate therapy. Not all kidney cancers need to be treated. We can watch a lot of them. We don't need to do surgery for a lot of them. We can cryoablate or thermally ablate them. There's even evolving data regarding the role of radiation for small renal masses. So there's a lot of options available now, 10 years from when we started, or 10 years ago to now, and it's a really different ballgame. It really is not a one-size-fits-all approach. Surveillance is very, very safe. Surveillance is not saying, hey, your doctor's not going to watch you ever again. It means we're going to keep an eye on the tumor and see how things change over time and reassess and modify. And novel imaging may further help stratify kind of how we treat these tumors down the road. So that's what I got. Any questions? Yeah, Joel, real quick.
In several Facebook communities, we still see lots of folks quoting their small-town doctors saying that biopsies are dangerous because of seeding. What can you, as a doctor, and other kidney urologic organizations do to educate these doctors? Because it's debunking that myth is one of the most difficult thing for us to
So I think an important thing is to know that generally it's not the urologist or the surgeon that's doing the biopsy, it's the radiologist. So engaging the radiology community at that hospital and having them be involved in that discussion and part of that pathway to say, hey, this is our technique, this is how we do it, this is what the literature shows, is really important. Because if there's not a good dialogue between the interventional radiologist, the nuclear medicine physicist that's reading the scans, and the urologist, then there is not going to be disseminated information, because it's now a real multidisciplinary approach even for small renal masses. So I think engaging the radiology community is very important.
And then one other, just a perspective of cryo versus heating from an ablation perspective. Do you have any principles or rules on that?
Institution specific. Some institutions are radio frequency ablation or microwave ablation predominant. The institution where I practice is cryo predominant. I think as long as you have a radiologist that has done a lot and is comfortable doing it, that's the most important thing, because it's done by interventional radiology. There are some urologists that still do their own cryoablation. I think that my personal opinion is I wouldn't do that. I would leave it in the hands of the pros that do it day in and day out. I'll focus on my surgery and they can focus on their percutaneous treatments.
I have a question about the PET scans.
Yeah.
So my insurance won't cover it. They're saying it's not valid with kidney cancer?
Yeah. Generally, PET scans are not useful for the detection of metastatic deposits of most kidney cancers. So there's really just a minority of kidney cancers that are PET avid. I think either a MRI with and without contrast or a CT of the chest, abdomen, and pelvis with and without contrast is kind of the most bang for the buck for staging of kidney cancers. I would agree that PET generally does not have as significant of a role in detection of kidney cancers.
Does it have any role with the follow-up for if it reoccurs or anything?
Generally, just a plain CT with and without contrast.
Thank you.
Are they developing a new agent specifically for kidney cancer in the PET scan area?
I think the girentuximab is the most recently evaluated one. I don't know of anything coming out for all kidney cancers in the PET setting because of the variability in the histologic subtypes. Yeah.
I was wondering, if you don't have a biopsy, are they still able to run like Signatera type testing without a biopsy?
No. So Signatera, for those in the audience, Signatera is a type of, it's called a tumor-informed circulating tumor DNA assay. So that's basically where they do a genomic sequencing event of the tumor, and then they look for the fingerprint of that tumor in the peripheral blood. So that's what's known as a tumor-informed assay. There are tumor non-informed assays where they look for more generic mutations in the blood that is not influenced by a patient's specific tumor. That could look for potential alterations. In general, renal cell, even in the advanced or metastatic sites, is not as much of what we call a tumor shedder in the peripheral blood compared to things like bladder cancer.
I know you just spoke about a PET scan, but does it make a difference what cell type of kidney cancer a person might have that might respond to a PET scan where another won't? Because I've had numerous PET scans, and that's what's showing my cancer. I have papillaries.
Yeah.
So that's why I was just wondering, does
Exactly.
your cell type have anything to do with it?
There is a subtype of papillaries that are they have this chemical effect called the Wardenberg effect where they may be able to be shown on PET scan, but by and large, even for papillary types, they would be seen on conventional CT-based imaging. Yeah, because the backbone of even a PET scan is still a CT scan.
Right.
Yeah. Anything else? All right. Well, I do have to peel off, but thank you everybody for your time and for your attention.